Hi everyone. Welcome to I think day 5 of Med Week. Second to last day, so kind of sad about that. But this is going to be really interesting. So I'm just going to share my screen for a little bit, and you guys can just follow along because we have a few more assignments from last time. So, okay, so welcome again. I'm super excited to have you guys, and we're just gonna get right into it. So I just wanted to introduce myself. So if you guys have already heard this presentation, I'm really sorry, but it's going again. So I'm actually a high school senior from New Jersey. I love to run and I play the violin a lot. And I'm obviously the founder of this organization, and it was started around May, June of this year. And you could find me at these two ats. And I also have a lot of community hours in hospital, volunteering, and shadowing. So usually you don't really see that in high school students, but I was able to kind of get a big start on that itself. And these are kind of some of my leadership positions that I have. So I just wanted to introduce kind of our organization. So it's a student-led and student nonprofit to kind of educate and advise students about the astounding medical procedures, careers, discoveries, and more. So we actually have 4 executive teams that are split up into researchers, editors, communicators, and graphic designers. And we usually pick a medical monthly topic every month that we usually research about, whether it be about orthopedics or pediatrics, or even mental health or BIPOC communities. And we have 50 tutors and 10 college overseers that help us with our tutoring platform and kind of tutoring STEM related subjects that you might encounter in your undergrad studies. And we also have 200 plus members, as well as a pre-med med panel, which I forgot to add, but it consists of 15 kind of dedicated undergrad students that are either pre-PA, pre-vet, or pre-med. And they usually release articles which can be like found on our Instagram. So these are just more of the stats. We have over 200 plus people involved with our organization. We've reached other nonprofits, and we have 3.5K plus followers, thanks to you guys. So I just wanted to kind of go over Medicine Week. A few of you guys are new here or might have signed up a little late to the call, which is perfectly fine. But every day this week, a medical professional or student will go on Zoom with us for an hour presentation and generally a Q&A session right after. So our panel board, we actually forgot to kind of introduce it because I wasn't able to kind of fit everyone in, but you can definitely look at our descriptions in our Instagram at medical.wonders for further information. So these are kind of the announcements that I wanted to make. If you were here on our 10 a.m. call, we didn't really have any new announcements. It was usually the same repetition of info. But I just wanted to go over that. Now we have our YouTube set up. So if you missed any of the calls, you can definitely rewatch them again, or if you want more pointers, and you can submit the kind of 5 to 6 paragraph summary of each call. So in order to do that, you must have attended 2 or more calls this week, and you must have signed up with your name and email on the Google form that we actually sent out. And obviously you submit the paragraph, and make sure you submit it after you've watched all the calls and after this whole week has ended, because it's going to be a lot for me to kind of keep track of everyone, and I don't need 10 different emails from the same person with the summary of the hours. And you can email it at this email right here, and it's also linked in the guidelines for medicine as well as you can find it throughout our Instagram. So when submitting the email, obviously put your full name along with the paragraph. And as for the summaries, they're due September 4th, 11:59 p.m. We wanted to kind of introduce this deadline because we didn't want more rolling summaries to come in and having to make more certificates. So we're going to cap it at September 4th, but we're still going to have the calls on, so you don't really have to worry about, even if you just want to listen for an information session, you could do that, but they're not going to be certifiable hours after that date. and how to list it on resume and application. So these are just two of the bullet points that you can. And if you attend all the calls, it's 12 hours worth of shadowing experience. So we have 6 calls throughout this week. So it's going to be 2 hours of shadowing or volunteer experience per call. And yeah, so that's really all I had to go over. If you guys have any questions, just please private message me. And I'm gonna stop sharing and I'm going to give it to our doctor. So thank you so much for kind of coming on and spending this hour with us. And I'm just gonna give it to you now to kind of introduce yourself.
Yeah, absolutely. Thank you so much for having me here. What's up, everyone? I'm excited to be here and teach you guys and give my advice and tips and tricks for my long journey in terms of becoming a resident physician. So my name is Darshan Shah, better known as Dr. Darsh on social media. So that's my handle on Instagram. And, you know, if you guys want to follow me on there as well, go for it. Message me, do whatever you need. I reply to everybody giving advice. I'm a pre-med mentor. I'm a medical school mentor. And my goal here is to just kind of give the realest advice possible. I'm not going to sugarcoat anything. So I think if this is correct, Sunny, we're going to go ahead and start with the case.
Yep.
Cool. So I apologize. In my post, if you guys have seen it, it said PM&R case, but I'm actually going to do a GI case because it's probably more like high yield and things that you're definitely going to see as you progress into your medical career. So I don't have slides prepared for this. I'm just going to kind of freeball it because that's exactly what we do in medicine. When you have an attending and stuff and you're presenting, you're kind of just going straight off of here and just saying things. So this is a real case that was last week. I was on night float at the VA hospital, and guy who is 65 years old presents to the emergency room. I go down and see him, and he says that he has blood in his stool. So I want to make this as interactive as possible as well. So because I want to teach you guys and, you know, get the key points that you need to know. So I'm just going to ask you guys questions as we go on here. So what are some things you guys want to ask this patient? And you guys can just type away in the chat. I'll just see things and I'll say, you know, and I'll just keep going. So go ahead. What should we ask this guy? This guy says he found blood in his stool whenever he has a bowel movement. So how frequent? Perfect. What's his diet? Awesome. When did this issue occur? Okay, so timing is big. Where does he work? When did it start? How long did it last? What has he eaten? Perfect, right? So we're thinking things GI tract, but the most important thing is how long has this been going on for? And the color of blood, exactly, perfect, right? And we'll get into that. So he says that it started, so he came in around 7 p.m. and he said it started the day before at 7 p.m. and then it happened again at 9:30 p.m. 2 hours after. He said there's about 3 cups of blood, and he actually takes a picture of his stool and shows it to us. Kind of disgusting, but it gives you a lot of good information. And so what you see in the picture is just bright red blood, but then you see little like dark formed stools as well, like black stools. So what do you guys think? What do you guys want to do from here on out? There's no family history of any colon cancer, no family any history of inflammatory bowel disease. Take it to the lab. So bright blood means it's fresh, correct? Any symptoms, test. Okay, so let's break this down, right? So we kind of understand here that he's bleeding, okay? This has never happened before in the past. This is kind of his first time. He's freaking out. What do you immediately want to do? There's 5 things you want to do whenever you find somebody with a GI bleed. Does anybody want to just go out and say, what are those 5 things? Okay, so his vitals are stable. He's completely stable. He doesn't have any low blood pressure. He's not like bleeding out. He's not actively bleeding, so there's no bleeding to really stop. So people are saying ultrasound, liver. So you guys are thinking of tests. Okay, good. But what are we doing emergently for this person, right? So what if he does start to lose more blood? What do you guys want to do then? Fluids. I'm seeing a lot of fluids. Perfect, right? Because whenever you see somebody with a GI bleed, you need to put in 2 large bore IVs. You need to call GI, right? Because they're going to have to either scope them, do a colonoscopy or something eventually. And then, of course, you're going to want to give fluids. So those are 3 things. And then the 4th thing you want to do is put them on a PPI, right? So a proton pump inhibitor. Now, these things are like omeprazole, pantoprazole. You guys may have seen commercials on this. Essentially what they do is block the acid in your stomach. And so when you can block that acid, it doesn't really mix with the blood. It helps the stomach lining kind of just soothe out. The other thing you want to make sure is their NPO. That means nothing per oral. So you don't want them to have them eat anything in case they have to go through surgery or something like that. Okay, so perfect. So you guys got that down. So now let's go through the color of the blood, right? So we see bright red blood, but also very dark black stool mixed in. So what does that make you guys think of? Like, why does the color matter in stool? So does dark stool mean a high iron content, fresh blood versus old blood? Perfect. Yeah, so fresh blood versus old blood. So if you see bright red blood, that's usually fresh blood, right? Because if you leave blood out, right, like you guys have all got a cut before, if you leave it out, what color does it turn, right? It gets oxidized and it turns into that purplish black, right? So the same thing happens inside your body. If you have an upper GI bleed, so usually above your duodenum and up, the blood has time to digest, so when it goes into the stool, it'll be really dark black. But if it's below the duodenum, it's a lower GI bleed. And in that case, it's going to be bright red blood, like bright, fresh red blood. So another thing we could do is a rectal exam. You actually go in, go to the rectum, swipe it, and then you and you swipe it to see what color it is. So great. Okay, that's exactly what you're going to do. So now we got to make sure that this person, one, is not actively bleeding, which he wasn't. We kept him NPO. He's got IV fluids. His vitals are fine. What else can we do? Now, what kind of imaging do you guys want to do to kind of figure out, hey, is it possible to see where, if there's any blood getting pooled or anything like that? So if you do an ultrasound, right, where would you do the ultrasound? So an ultrasound doesn't penetrate that deeply, right? So if you do an ultrasound in the stomach, and I'm going to tilt this down here, if you do an ultrasound in the stomach, you're only going to see the abdominal cavity, right? So if you think of anatomy, and I'm going to turn this way. Here's my stomach. Okay, there we go. Here's my stomach. I've got like a peritoneal cavity, and then I have all my intestines after that. So an ultrasound won't necessarily penetrate that deeply. So we're not going to do an ultrasound. Ultrasound's good for liver lesions, things more on the surface, something like ascites where there's fluid in your abdomen. So I see CT scan, endoscopy. Okay, perfect. Yeah, so a CT scan, right? So we're going to do a CT scan of the abdomen and pelvis and see with contrast, hey, is there something that can really tell us if there's any blood getting pooled? Awesome. Okay, so we get the CT scan back from this guy, and what we find is actually very interesting. He has a diverticulitis in his sigmoid colon. Now that's something that happens in older age people, and this guy's 75 years old. Now what a diverticulitis is an outpouching of the colon, right? So you have your colon, think of it as a hollow tube, and then within that tube, think of the wall kind of just forming a pouch. So if this is your colon, like this, you're gonna have a little pouch sticking out. But because it ends in itis, right? So tendinitis, synovitis, all the itises, itis means inflammation. So with diverticulitis, this guy essentially has an inflamed colon, outpouching. And that can sometimes bleed. So, okay, that could be definitely a source of his bleeding because it's a lower GI bleed and that's where the bright blood comes from. But what are some causes of an upper GI bleed that could maybe explain why he has darker stool? So I see injury, buildup before. So there's a buildup. So think about what can bleed from your stomach and above, right? What are some causes that could cause that? Gastric ulcer, perfect. Yeah, that's one. Stomach infection, right? Like H. pylori, if you guys have heard of that. Helicobacter pylori. Ulcers, I'm seeing a lot of ulcers. Yeah, ulcers are probably the most common thing that we see in people with an upper GI bleed. Acidity abnormalities, exactly. Maybe your stomach's not making enough acid. Maybe your gastric lining is too thin, right? Okay, now what about above the stomach? What about above that? So you guys pretty much got the stomach stuff, right? Not the heart, esophageal bleed, right? Exactly. Esophageal tears and esophageal ulcer. Maybe, we see a lot of alcoholics, and what happens when you drink too much alcohol, you start to throw up, right? And you can throw up so much that you start to tear your esophagus. That's called a Mallory-Weiss tear. And you can start bleeding from that. Cancer in the esophagus. Sometimes even the oral cavity. So sometimes you have to ask them to go, and look to see if there's any dried blood, because it might be kind of far back, but they might just be swallowing it the whole time. So awesome, you guys got the upper GI stuff, right? So pretty much stomach, esophagus. You can have something called an arteriovenous malformation, which is where the arteries and the veins kind of get tangled up in the colon. or the small intestine, and that can slowly bleed out too. What are some other causes of bleeding in the lower GI system? So we have diverticula. What else can bleed down there? I see varices for the esophagus. Yeah, exactly. That's one. Would an upper GI bleed also cause darkened stools? Yes, exactly, because the blood has time to digest. Yeah, hemorrhoids, right? That's like, so there's external hemorrhoids, internal hemorrhoids. So you got to check for hemorrhoids, right? That could definitely be something. So hemorrhoids is something. What else? What else in your colon or small intestine can make you bleed? So a hernia is usually something from the outside, right? A hernia is either in the stomach or the inguinal like cavity, and that's more of the muscle coming out. So a tumor, right? Colon cancer. So if you ever have a patient who's like over 6 years old and you see that their iron is low, that they're iron deficient, you suspect colon cancer, and you have to rule it out until you can find another cause. So appendix is not in the GI, right? It's in a kind of separate cavity. Perforations, exactly, yeah. You could have a perforated colon. So kidneys are in your retroperitoneal, so it's not in the same alignment. Gastritis. So what about things like inflammatory bowel disease, right? So Crohn's disease, ulcerative colitis. If you guys have heard of that, there's also a lot of commercials about that with all these biologic medications that you can use for Crohn's and ulcerative colitis, things like that. Maybe a small bowel obstruction. Maybe you're constipated, and you know your bowel is kind of just pushing up against your colon wall. So there's a bunch of different causes for GI bleed. So it's very important whenever you see somebody with a GI bleed to kind of go through that and first think, is it lower or is it upper based off the blood? Now that doesn't hold true all the time, but that's how you have to think. So now, okay, we understand this guy might have both. The diverticulum might explain his lower GI bleed. So what do you guys want to do now? So GI has been consulted. We call the GI team and they say, okay, don't make him eat. We're going to do some stuff tomorrow. What is that thing that they're going to do? No, it would not be related to liver or pancreas. Yeah, an endoscopy, right? So if you have upper GI bleeding, you're gonna do an endoscopy, right? So what are they gonna do? They're gonna do an EGD, esophagogastroduodenal, right? So esopho, gastro, and then duodenal for the small intestine, scopy. So just viewing it with the camera. So they went in and they found an ulcer, and they found about 2 ulcers. Now, what are some causes of gastric ulcers? High acidity, spicy food, sure. What else? What else can cause a gastric ulcer? H. pylori infection, perfect, right? Very, the most common bacteria that will cause an ulcer. Drugs, yeah. What kind of drugs will cause ulcers? Something common that everyone takes. NSAIDs, yes, right? So NSAIDs, ibuprofen. You see a lot of patients who don't know that NSAIDs can wear away your lining, your mucosal lining. And so I had a patient last month who also came with a GI bleed and said, yeah, I take about 3 NSAIDs a day, 3 ibuprofen tablets a day because it makes my headaches go away, or I'm just so used to it now that I just take them. What do you know? He has like 5 or 6 gastric ulcers. Awesome, yeah. Too much alcohol can cause ulcers as well. So there's a bunch of different reasons. So what do you want to do once you see an ulcer, right? You want to biopsy it. And then there's things that you can do to stop the bleeding. You can cauterize it. I think in this patient, we also found a polyp. So we clipped the polyp and we put a staple. So there's a bunch of different things to do, but you definitely want to biopsy that ulcer to make sure it's not malignant, to make sure that there's no cancer growing in it. So perfect. All right, you guys got that right as well. So now what are we going to do for a lower GI bleed? And I think, you know, a lot of you guys already said the answer, but you're going to do a colonoscopy, right? You still want to do a colonoscopy just to make sure. But the thing is, when somebody has a diverticulitis, you actually don't want to do a colonoscopy, right? Because there's inflammation. And what happens if you go in and you mess with that outpouching, right? So here's the colon and there's a little outpouching. What if you go with a colonoscopy and you're going to perforate it, right? And now you're even more screwed from when the patient first came in. So that's a contraindication to really doing a colonoscopy. But important things to ask, right? This patient is, when was the last time you had a colonoscopy? What did that show on your last colonoscopy? And then if that patient didn't have a diverticulitis, then yeah, you definitely want to do a colonoscopy and see, hey, is there a polyp? Are there strictures? Is there a fistula? Are there hemorrhoids? What exactly is going on here? Do we need to do surgery, or how are we going to manage this, right? So one interesting fact that we're seeing here in the US is the number of cases of colon cancer that are really popping up in people age in their 30s. And GI docs aren't really sure what it's probably due to. A lot of them think it's probably like the processed food that we're all eating now. But we're really seeing an uptick and rise in colon cancer and GI bleeds. So the reason I'm presenting this case is because this is probably my like 6th GI bleed I've seen now. So let's go over some lab markers now, right? So this guy has a GI bleed. What lab value do you really want to look at with somebody with a GI bleed? Okay, iron levels. Yeah, that's something we can do as an iron panel to see. Well, why would you get an iron? What is that going to help you with in terms of a diagnosis? So how do you so how do you measure anemia, and what is in the CBC that you're looking for? And that means complete blood count. So white blood count will tell you inflammation. RBCs are just going to tell you how much red blood cells there are, but it won't necessarily tell you the bleeding. Hemoglobin, there we go. Yeah, so hemoglobin is actually what we look at as a marker for anemia to really see if someone's bleeding. So if this patient came with, a hemoglobin of 6, but his baseline hemoglobin is usually like a 12, and normal's around a 13 to 15. But if he had a 12 and he went to a 6, because it dropped so rapidly, you would probably see symptoms of him being dizzy, passing out. And I forgot to mention, but those are actually some of his symptoms, where he felt dizzy, he felt like syncope, where if he were to get up, he'd fall back down. He felt tired all the time. So hemoglobin is something we look at to really tell us, is this chronic blood loss? So if it went from a 12 to like a 10, and then 10 to a 9, and then 9 to an 8 over a long period of time, he's not going to have those symptoms because your body really adjusts to losing that blood. But when you go from like a 12 to a 6 very quickly, then yeah, you're going to get those symptoms. So what do you do in that case? We're going to transfuse blood. This is where giving blood helps out, right? This is what we do it for, is for patients like that where they need blood. So you transfuse units of blood, and usually the rule is 1 unit of blood will get your hemoglobin back up by 1 point. So if somebody's at a hemoglobin of 6 and we give them 2 units of blood, their hemoglobin should go back to an 8. Sometimes they'll go higher because they'll start to get iron, and iron can help produce more of that erythropoietin. So that's essentially what we did with this patient. I don't think we transfused blood though, because I think his hemoglobin was at 8.5. So essentially this case was now medically managed. So what are some things you want to tell to a patient, right? Because I'm all about preventative medicine. I want to do functional medicine eventually. I'm in PM&R, I'm all about patient education. So what are some things that we can tell this patient to really just help his lifestyle out? Yeah, healthy diet, right? So including fiber in your diet, right? Because fiber is gonna bulk up everything and then push everything kind of out, right? Make a more formed stool. Because when stool is left in the colon, again, it's just bacteria sitting there, and it can cause tears and things in the colon. So you definitely want to push that out. Moderate NSAIDs. So actually no NSAIDs at this point, right? We're going to say you don't want to take any NSAIDs because that can just further cause issues. You want to take Tylenol instead or something. Exercise, yeah, don't do drugs, moderate medications, exactly. PPI for some time, proton pump inhibitor, exactly. Monitoring his stool, making sure he checks, making sure when he wipes, he's checking the toilet paper to see if there's still any more blood and stuff. And then making sure that he's getting a regular colonoscopy. So now we're going to treat his diverticulitis. We gave him some antibiotics to treat that. But then once that resolves, he really needs to get a colonoscopy now, once every year, once every 3 years, just to make sure that everything's fine with him. So avoid the cause, any potential causes, no alcohol, iron pills. Yeah, so we can definitely also give, oh yeah, sorry, let me go back to iron and why we check iron. So once you know there's anemia, there's different types of anemia, right? There's microcytic, which means that the red blood cells are small. There's macrocytic, which means they're big, or there's normocytic, where there's just a normal size. And each of those categories have different causes behind them. So when you look at microcytic, That means usually there's an iron deficiency, and that's what we mainly see in patients. But when you look at macrocytic anemia, it's usually called by a folate deficiency, B12, alcohol use, and you'll definitely see that as well in patients. But in this case, we saw microcytic, which means he had an iron deficiency. Now, doing something with iron really depends on how low it is, and it really depends on the route that if you're going to give it IV or orally. And that's a whole other topic, to discuss, and actually a lesson that I was learning today, because we actually had a patient who had gross hematuria, where he was bleeding from his penis, and due to a bladder cancer, and his hemoglobin went to a 6. And so we were talking about iron and how to replete that, and it's a whole other science. So that's essentially my case. This patient ended up doing well. He left about 3 days ago. He was only in the hospital for like 5-6 days. But eventually he got fixed up and his bleeding stopped, got a staple, removed it, had the diverticulitis, was on antibiotics, so that should resolve as well. So overall, it ended well for the patient. If you guys have any questions, I can, answer here for a little bit. So I think the main keys here in this case are, one, knowing the color of the stool and knowing is it upper, lower, and knowing the causes of that. Number two, once you have ulcers or things like that, what are the causes of that? What did the patient do? How did the patient get the bleed, right? There's usually always a cause behind the bleed. So understanding that. And then three, looking at it is if it's anemia, looking at the hemoglobin and then seeing, hey, do we need to transfuse or do we not need to transfuse? I think those are like the main key takeaways from this case. And again, it's going to be something that you're definitely going to see once you're a resident or once you're in med school that you're going to learn about. 5 things for GI bleeds. So IV, bores, call GI, give fluids, PPIs. Why am I missing the last one? It's not NPO. It's not don't let them eat. I'll think of the last one. I don't know why I can't remember it. There are 5 things to do. I said consult GI though. So I do have, if you guys like these types of cases, if you go to my Instagram, the IGTV, I do have about 15 to 20 hours worth of cases where you guys can go through, and it actually counts as a med school application activity that you can put down. So if you guys just want to learn medicine, I teach it just like I did now. Those cases are a little bit more in depth. I kind of just like freeball this with whatever I had in the hospital. But those are about an hour-long cases where I take you through the history, objective, assessment, and the plan. So if you guys do like these cases, check out my Instagram TV. You'll definitely see some more. So I don't know if it counts as shadowing hours. I had a student ask her pre-med advisor, and she said probably not, because you're not necessarily in the hospital shadowing me. But I mean, I don't know, right? Like, and I guess it depends on what you kind of want to put it as. But it definitely does count as an activity to say like, hey, I'm learning the gray area of medicine. I'm learning exactly how doctors think, right? Because how many times when you go shadow, the doctor's explaining each and every step and teaching you, right? Not often. You're kind of just sitting there, sometimes a fly on the wall, just seeing what the doctor is doing. And if you're lucky, they'll explain to you some stuff. But these are literally dedicated lectures each hour, just about whatever topics. I have cardiology on there, neurology, GI, endocrinology, and pulmonology. So those are like the high yield cases that you definitely will see when you're in the hospital, like your bread and butter medicine. Are you content? So I'm not doing any more new cases, just because of residency and I really don't have time, but they are all on there. 15 to 20, if you just go on there and click and see series, you'll see the cases. So, okay, so like something misdiagnosed as benign when it was actually malignant. So that's why you do the biopsy, to really see if it's malignant or not, just so you can really make sure that that you're not missing something. So if it is malignant, you actually do treat it as a cancer. How long do biopsies take? It really depends on the place. Usually like 3-4 days to kind of just look under the microscope and then write the report and get it back to the patient. When you talk about your experience in medical school, yeah, so I think that's exactly what we're just about to get to. So,
Okay, yeah. So I'm gonna just disable the chat right now because it's just a little kind of distracting. So I kind of put your questions together if you guys left them in the Google form first. So I'm gonna be going over that, And then if you guys have further questions, I'll open up the chat again to kind of ask the doctor today. So I guess the first thing is kind of going over your background of, how your undergrad, medical school, kind of like a basis of how you kind of ended up where you are.
Yeah, and I'll try to keep this brief because it's a long story, but when I get more questions, I can delve into advice at different parts of my journey.
Yeah.
So in high school, and I always talk about stats because in the end, you guys will realize that stats don't actually matter. So in high school, I did pretty well. I got 2140 SAT. I was ranked number 19 out of 1,056, top 2%. My GPA was like a 3.9 something, weighted 5 point something out of 4. So I did pretty well, varsity athlete. I had a stellar application. I ended up actually applying to a 7-year BS DDS program, so the 7-year dental programs, thinking that, hey, I might want to do this. My brother's a dentist. I thought it was pretty cool, great lifestyle. And then I ended up going to Temple University, got accepted to their 7-year DDS. Until halfway about the first semester, I realized I just don't want only an oral cavity approach. I'd rather have a full body approach. I really love MSK. I was an athlete my whole life. I just really enjoyed human physiology. So I asked them the Health Scholars Program, which is a 7-year BSMD program, because we were kind of all joined together in a cohort. Hey, can I switch over? And she said, yeah, that's completely fine. I had the stats and stuff to switch over. So I was now officially in the 7 or 8-year BSMD program. And what was kind of annoying is that we had to either be a biology, biochem, or a chemistry major. So I chose bio, as do most pre-meds, and we'll touch on what I feel about majors in a bit. And essentially, I struggled in college because it wasn't like high school. And the problem was I never took the time to actually fix my habits and to fix my studying. Honestly, I never studied. That was the issue. Whereas in high school, homework was my studying, right? If I did enough homework and I reinforced the topics, I was going to do well in the exam. When I went to Temple University, I barely had any homework. It was all just, hey, we have an exam on this day. This is what we're learning in class. Go out, figure it out, and come back and take the exam. And that really did not do well for me. So after my first year, I kind of ended around a 3.5, 3.6 GPA. And then my second year, I got even harder with genetics and orgo, OChem. I probably dipped around a 3.4. So I was hovering around this 3.4 to 3.6 range every single year. And then, I had to take my MCAT on top of that. And the first time I took the MCAT, I got a 25, which is probably equivalent to about a 500, I would say, on the new ones. And the program requirements were a 3.5 GPA and a 30 on the MCAT. So I had to take the MCAT again. Luckily, I got a 30. I fixed my studying up for that. I really fixed my cars, or verbal back then. And that's what helped me get that 30. My GPA, on the other hand, I don't know what it was. I never took the time to really figure myself out and figure out, hey, my back's against the ropes. I really need to figure this out. And so I ended my junior year, which is when you needed the requirement by, with a 3.48. So I was 0.02 away from matriculating into Temple Medicine. Unfortunately, there's no exceptions. You have to get it. And at that point, I'm thinking, okay, what do I do? I didn't think I'd be in this position. My family has told everyone I'm going to become a doctor, and I'm in a 7-year med program. You lose your pride, you lose your confidence. And I never thought I'd have to apply out for med school. So here I am saying, okay, well, I have to have a gap year now. Well, not necessarily. I applied after my junior year, thinking, hey, I might not need a gap year. Didn't get in, got a few interviews from some schools, didn't really apply to DO schools that much. At that time, there was still a big stigma in terms of DO, MD, all that kind of stuff. So I only applied to really 2 DO schools, I think, PCOM and LECOM, because I'm from Philly. Didn't hear back from them, only got 2 or 3 interviews from MD schools, didn't get accepted. So I said, man, okay, this is kind of a wake up call. I really have to look at my resume and see what can I do to improve it. When you look back my undergrad, I didn't really have any meaningful activities. I was part of a bunch of different clubs and groups. I was part of a dance team my first semester, and then I joined a South Asian fraternity that second semester, which was, volunteer fraternity, so they say. And then, I joined things like AMSA, which is the American Medical Student Association, things like AED, which is a med school club. And, I didn't have any leadership positions per se, because growing up after 6th grade, I actually developed a stutter. And that stutter held me back from just so many things that I, wanted to accomplish, because honestly, I was afraid of giving a 30-second speech if I had to run for president or secretary or treasurer. But if it was a mail-in vote, sign me up, I'd do it, because I won't have to give a speech. That's how afraid I was, and that's how much I was holding myself back, until I realized during that first gap, you're like, hey, I really need to figure something out. So at that point, this was about 8 years ago, scribing was not really a big thing then. So Scribe America was the company that I worked for. I worked at CHOP in Philadelphia, which was, and I did a pediatric emergency medicine scribe. So I was there for about 9 months. The thing with scribing is it's a great experience. You really see the behind the scenes of how doctors interact with nurses, with techs, all that good stuff. The problem is after 9 months, you kind of plateau with your learning. The learning curve is steep, but then you're like, all right, I can't learn much. So I was contemplating if I should leave or not. And I came across this quote by Robert Two, and he says, don't be afraid to walk away from something that no longer grows you, serves you, or makes you happy, right? No longer grows you, no longer serves you, or no longer makes you happy. And scribing was no longer serving me. It wasn't growing me either. I just, I was plateauing. So I said, okay, I'm gonna leave here. And I decided to apply for a job, and I ended up becoming a virology lab technician at a pharmaceutical outsourcing company. So kind of like research, but more of a job where you're actually culturing cells, figuring out if there's pathology in those cells, et cetera. So I did that for about 9 months. And what was interesting was it was a paid employment. It was like my first real job. And it's weird being a pre-med having a job because we don't realize like our business, peers do, or computer science peers where they do internships and stuff, about how important communication is, how important it is in the real world to like be politically correct and like say the right thing, say goodbye, say hello, good morning, and like really just be interactive and like learn how to be a person. So that experience really taught me a lot. But again, after 9 months, it was just a malignant place to be. So I left. And then this was my second time applying for med school. And I got into VCOM. But the funny thing is the VCOM secondary application went to my junk email, and I didn't see it until December, and they sent it in like September. So I emailed them quickly and I said, hey, like I can't find my email. They said, look at your junk. It was there. I told them. They said, no worries. Just send it in as soon as possible. Send it in 2 days. They gave me an interview. I had an interview in late March. Late March is pretty late to get an interview for med school. At that point, I was hoping, hey, maybe I have a chance to get in, but if not, maybe I get waitlisted. And so I did end up getting waitlisted that second time around. And the good thing about VCOM is when you get waitlisted, you pretty much get accepted the year after without having to go through an interview or anything. So I knew that going into that third application cycle, but I didn't want to take any chances. So I applied again, and this was pretty much going to be my last chance applying because at that point, my MCAT was going to expire after 3 years. And I had 3 choices. I can either go to St. George's, like the Caribbeans, which I got into, and I was not a big fan of that. I either get into med school and I go, or I can do something like a master's in exercise physiology or a PhD or pursue something of higher education. And I was really heavily leaning towards going to that PhD MD route or PhD route, master's route. So I actually cold emailed about 50 professors from anywhere from like Maryland all the way to Boston that worked in exercise physiology, just trying to get a position and say, hey, I'm willing to work in your lab. I ended up working at UPenn, and this was a free internship. So I even told them like, hey, I'm not even looking for money. I'm just looking to get in my foot in the door. And that was probably the best experience I ever had, was being at Penn, working with breast cancer survivors and looking at diet and exercise. But it wasn't the research that I was doing that was awesome. It was that my principal investigator tested me and pushed me and said, hey, do you want to present at a big conference and do an abstract? And what I learned from that is never say no when there's an opportunity, even if you don't know how to do it. Because the thing is, the minute you say yes, your butt's going to be on the line and you're going to learn real quick how you have to accomplish that goal so you don't look like a fool, right? So that's what I did. I learned how to write an abstract. I learned how to collect data. I learned how to analyze the data, and I ended up presenting. Next thing you know, I'm done with that lab. The lab's kind of over, and she leaves Penn and she ends up at Penn State Hershey. So I end up going to medical school. I go through my 4 years, and then I apply for physical medicine and rehab. And so I applied, and then I matched at Penn State Hershey. So it's funny how things work full circle. She works with a lot of the physical medicine rehab residents there. So I'm pretty sure for me to say yes to that abstract, for me to put my best foot forward, for me to help her for free, but still go above and beyond and do the things, that were out of my comfort zone, she probably had a big say into me coming there, that I believe. I don't know for sure, but I'm definitely gonna contact her and see if I can work in her lab again. So it's funny how things come full circle. So putting your best foot forward is very, very big. So again, I went to VCOM, Virginia, so Virginia Tech's DO school. for medical school, 4 years there, got really interested in physical medicine rehab, applied for that, and now I'm at Penn State Hershey. So kind of a long-winded journey, but I think we can delve into some of the specifics here and the advice that I would give.
Yeah, definitely. So before I kind of open it, because we're a little crunching on time, I would kind of, so one of the major questions is kind of like, what would you change, I guess, about your journey, if it would be anything, or what did you know kind of before, going through all of these obstacles and stuff like that?
Yeah, absolutely. So I would not have applied to a BS DDS program or a BS MD program. The reason I say that is I don't think anyone at the age of 16, 17, or 18 truly know that they want to go to medical school. I think we all love the idea of medical school, and this is no offense to anyone here. I think this is true for any single 17-year-old or 18-year-old, including me. Because oftentimes when we say we want to go pre-med, we don't actually understand the politics behind it or the burnout behind it and what being a doctor truly can be. And it's not just about saving lives and learning medicine, but there's a whole nother world attached to it. And I think a lot of people, when they say they're pre-med or they go into a BSMD program, you get blinded solely to that field. And so even when you think you may not want to do medicine, oftentimes we don't back out and we go through medicine because, one, we're already in a program, our lives already made out for us, it's easy, but we're already on a track, it's hard to jump out of that track. And I think not having that ability to jump out and explore different options, even if you do end up coming back to medicine, I think anyone's at a disadvantage for doing that. So if I could go back, I would not have applied to a BSMD program, and I would not have been a science major. I would have done probably economics or business, and then do a pre-med minor, right? So a minor in bio or something. The reason I say that is college is the last time you will truly, truly, truly learn something in a different field for the last time, right? If you ever want to learn world history or philosophy, do it. That's the last time you're ever going to get a chance. Because the minute you go to med school, you're slaving your life away with medicine and science for the next 50 years. And none of those classes that you take, the biology, the chemistry, the orgo, the physics, none of it will help you in med school. None of it. So you might as well take that opportunity to enjoy college, learn some new things. And you never know if you change your mind. You might like business, you might like computer science, you might open up other opportunities. And then if you do end up going to medicine, even better, because now you can extract new ideas, you can extract a new skill set from business, from computer science, from philosophy, from world history, from English, whatever it is. So I'm reading this book called Grit by Angela Duckworth. I highly recommend everyone watching the TED Talk. It's not that long. It's by Angela Duckworth, called Grit. And she pretty much talks about how, if all these professional swimmers or athletes, right, if you want to become a professional swimmer, most of them don't just start swimming and that's it. They tried basketball, they did swimming, they did tennis, they did baseball. And then they tried a bunch of different things and they realized, hey, I would probably be really good at swimming. Let me delve deeper into it. So they did, and they found out they were even more proficient. The thing is, if they just did swimming, they probably wouldn't be that good. But now that they're a swimmer, but they have a background of basketball, baseball, tennis, and all these other sports, they can use those skills and it makes them an even better swimmer. And that's how I feel medicine is. Medicine is not just a one-stop shop. Science is, that's it. If you can learn business and be an entrepreneur, even better. You can learn to open up a practice. You can learn to work with biotech companies. If you know how to code, even better. You can really delve into research and really help a lot of labs out. If you know English, perfect. Also with research, you can write really well. Philosophy, even better. Ethics, right? So there's always some correlation with medicine and the rest of the humanities in the world around us. And that's why if I could go back, would not be a biology major.
All right, that sounds good. So we're just gonna open it up right now to the floor because we have about, I'd say like 15, 20 more minutes left. So if anyone wants to ask anything, and you can just kind of go through all of the questions.
Sure. What are some important qualities to have in med school? Honestly, just being committed, right? It just comes that, so I like to say med school, I think, is easier than undergrad. You're not chasing a grade, you're not chasing a GPA, you just got to do the work. It comes down to discipline, it comes down to your habits, and that's all med school is. If you can solidify those and build a lifestyle now, you're gonna be great for med school. Put my glasses here. All right, how do you juggle med school and outside activities? So I developed this very early, and I told myself, I'm not gonna let myself be defined by being a doctor. I'm gonna be, doctor's what I do, it's not who I am. And so I always made a point before I studied or before anything, I would read my books, I would meditate, I would work out, I would do everything I had to do, and then I'd go study. Because in the end, if I didn't study, I knew I wouldn't be in med school, right? So that's the way I kind of made my day. My sister is studying for the MCAT right now. Do you have any study tips? Sure. So the big thing I say is don't listen to anyone's advice. Everyone who does the MCAT is going to have it differently. The biggest thing I'll tell you is know the type of studier you are. Are you someone who needs only 1 to 2 months and studies 8 to 10 hours a day, or someone who studies 4 to 6 months, maybe a little bit a day? And then do a lot of questions. I ask people and people tell me they've only done 3 or 4 practice tests. I think you should do about like 15 to 20 because you really need, and start from day one and do a practice test and just keep going every 5 days, do a practice test. So it's really about seeing your trend and then seeing where you plateau and then breaking through that plateau. Once you break through that first plateau, that's where you want to take your exam. This is random, but do you have a TikTok? I feel like I've seen, yeah, I do. It's the same thing as my Instagram at Dr. Darch. I'm not that big into TikTok. I do a lot, everything I do is on Instagram for the most part. And guys, if I don't get to your question, just go ahead and message me on Instagram as well. I respond to everyone. Is it true that med students have no social life? That is false. Med students probably party harder than anyone I know. Can aortoenteric fistula cause GI bleeding? Yeah, it could, right? It's going into the GI system, so absolutely. What was the most memorable moment in med school? Man, that's a tough one. I think, honestly, well, I got engaged to my now wife in med school, so that was pretty memorable, right? Like just having a relationship and getting through it. Honestly, I think all of med school is just memorable. Hardest year in med school, there is no hard year, really. It depends. I actually thought first year was harder than second year at VCOM because you're just getting used to everything. The classes can be tough, tougher. It depends on the school. Do you think you have to be an extrovert to be? No. So I talked about this yesterday actually in the talk. You don't have to be an extrovert. You have to be a great communicator. And that doesn't mean and extroverts are only good communicators, and introverts are great communicators as well. But it really comes down to listening, having empathy, having sympathy, and understanding nonverbal communication, as well as just like being eloquent, talking to your patients, getting out. And if that's something you struggle with, like I did, I had fear of public speaking. You got to break out of that. Go to a Toastmasters, start to give talks, start to just do things that really stretch you out of your comfort zone, and you'll get better at it. How do you deal with, what is your specialty? So I'm in physical medicine and rehab. So essentially 2 components of it, physical medicine, which deals with musculoskeletal neurology kind of stuff, and then rehab. So people who have strokes, brain injury, spinal cord injury, they have deficits. Sometimes they can't walk, things like that. So they have to get rehab back into being functional. Let's see. How do you deal with the judgmental elders who ask why it's taken? Don't worry about it. Listen, everyone, be on your own path. There's no right way to medical school. The average age of a first-year medical student is 25. And that's why I really recommend taking gap years. You really need those 2 years to show med school's commitment, being in the up and down journey of whatever it is. For me, that was the research, that was being at that pharmaceutical company, and that was me as a scribe. I did a 3-year stint where, med schools asked, oh, you switched from here to here. And I explained that. I explained it was no longer growing me. Excuse me, it was no longer serving me. But med school and medicine is that one thing that will always grow me, it will always serve me, and it will always make me happy, as well as my patients, right? So what do you think made you stand out? I think essentially that. I think I came in with a theme, and my theme was resilience. My theme was personal development. I'm all about reading books, figuring out how to become the best version of yourself. And that is my perspective in life. It's all about passion. It's all about figuring out your passion, and the way of doing that is go out there and try many different things. And I always start my talks, and I didn't start this one, but my 3 goals are 1, to confirm your love for medicine, 2, make you not want to go to medicine, and 3, leave you in the middle and very confused. And I think when you can go through all 3 of those phases, you're in the perfect boat, because that means 1, you thought about medicine, it's still in your back pocket, you might go back to it, but you're also not afraid to go out and try other things. And, if I could go back, I would still be a physician. So I'm not saying don't become a doctor. I'm just saying it's very important to follow what your calling is. And oftentimes that's not medicine, especially when we think about it as a 17, 18, 19, 20-year-old. Our idea of medicine is very different because you're not actually gonna be a doctor until you're about 30, 31, 32, and you're gonna want different things. So it's 2 different thought processes at 2 different ages. And it takes a while to mature our mindset. If I look back at myself at 20 and 25, man, I was a whole different person with a whole different mindset than I am now. And it's still going to evolve to when I'm 30, 35. So just keep that in mind. Do you feel like leadership positions in clubs elected are a popularity game? They could be, but they're very important. And the reason I say that is med schools look for impact. So if you're gonna go for leadership positions, make sure you do it. But always make sure you're thinking about how can I serve the people here and how can I grow myself, right? So make it a personal development journey, but also try to influence people, try to spark change, create something, right? It's about creating. And med schools like that. Med schools like to see you create something and have something to show for it. Was it hard having a relationship during med school? Yeah, it definitely could be tough. I got lucky because my wife, her brother is a neurosurgery resident. So that's pretty, probably the most busiest specialty there is. So she knew going in, me going in that it was going to be busy. But we worked it out, frequent visits, stuff like that. So, and now we live together. So it only makes it sweeter. What would you recommend to high school students that might be wanting to go into the pre-med path but aren't 100% sure yet? Yeah, choose another major that interests you, right? But still take those pre-med bio classes and shadow. So just go and see, do you like what you're seeing, or are there other things that are sparking your interest? Again, I don't think anyone's super sure until maybe their senior year of undergrad or maybe after some gap years. And that is why med schools also prefer gap year students now, I think, where the average age is 25, because you really start to understand, hey, this is my passion. And even though I'm 25 now or 26, I'm still going to apply to med school. So does your undergrad college influence your chance of getting into certain med schools? No, not necessarily. So your major doesn't matter and your undergrad doesn't matter. What matters is your GPA. And so I really honestly tell people, go to an easier undergrad if you need to. I went to Temple and it was ridiculously hard. I probably would not have gone there again. It's not worth going to a school where when you take genetics and there's 320 students, they only give out 10 A's. And that's a hard rule. So it's just not worth it, Any big personality difference between people who want to go into research versus people who want to go into clinical practice? Not necessarily. So there's a lot of people who do both. You can do both. You can go into academic medicine and practice, but also be really involved in research. And you can get to the point where you can choose what days you want to do research and what days you want to do clinic. So it's definitely possible. Do you think it would be difficult to balance being a pre-med and a humanities major? It really depends on the school. It depends on how active you are and how many things you're doing. But it's not impossible, for sure. It's not. I mean, med school is like 30 credits, right? Like a semester. So you definitely can figure it out. What's the greatest lesson you've learned throughout your journey thus far? Man, that's a great question because I've learned a lot. I think the most important thing I've learned is striving to become 1% better every day. Focusing on yourself, not comparing yourself to others, staying on your path, and just living within yourself. And really just figuring out, how can I be better tomorrow? What is the one thing I can do? Just become 1% better. And if you compound 1% over 365 days, you end up becoming 37 times better than who you initially were. Now, 37 times is a lot, right? If you think of it, if you play the stock market and your stock's at $1 and it goes up to 37 by the end of the year, and you put a lot of value in that, you're going to be rich, right? Or you're going to be making a lot of money off that. So think about it that way. So just strive to become 1% better each and every day. Thoughts about studying abroad? Yeah, absolutely. Do it. Oh man, that's one thing I wish I did too. Didn't really do it because there weren't many science classes that you could study abroad with Temple. If I was any other major, 100%. I mean, it's just like I backpacked to Europe right before med school, and I just thought, man, why wasn't I doing this before? Like, you only live once, guys, honestly, and your 20s are the greatest time of your life. Don't waste them. Don't lose them. Take your time, develop yourself, enjoy, travel, and figure out what you're passionate about.
All right, so I think we're gonna end it there. Thank you guys so much for kind of coming on, and I'm gonna re-disable the chat right now, and I'm just gonna do a poll right now. Dr. Shah, if you could just put your kind of Instagram again in the, I guess,
The
the
chat.
chat and the email, yeah, so just people are able to know. And if you guys could just put kind of respond to this poll, because I want to see how the Zoom call went, because we were having a few technical difficulties with that. So you can let me know on that. And yeah. All right. So majority, it went pretty good. So I'm glad. And yeah, I mean, we're gonna end it here. Thank you so much, Dr. Shah, for kind of coming on and doing this case study. And it was very insightful, you know, dealing with a lot of obstacles and setbacks and stuff like that. And yeah, I just wanted to thank you, and I learned a lot, and I'm sure others did as well. So
Yeah, absolutely. Thank you so much for having me here. Like, I really enjoy this. And guys, honestly, if you do want to message me, I know I didn't get to everyone's questions, but you can reach out and I will definitely reach out back to you even tonight if you want. So reach out and I'll try my best to help anyone here. So thank you again for having me. I really enjoyed it.
yep, and make sure you guys stay tuned tomorrow at 12 p.m. We're actually gonna have a PA student take over with us, so you'll get a lot of insight on kind of PA school and how she's going to manage it in the future. So yeah, thank you guys so much, and you guys are now free to go. Bye. Yeah, Dr. Shah, you're free to go unless you want to talk.
Yeah, no worries. I was going to stay in here just in case, like,
Okay.
anything, but everyone else is muted, I guess.